today, and he comes in the door very dramatically, let me just say, very dramatically, coughing, complaining of severe shortness of breath, states he's been vomiting, has a burning sensation in the back of his throat. He rates his pain at a level of 5 on a 0 to 10 scale, and when you ask him where that pain is, he says that it's his throat. But he is thrashing about that bed as if the pain is much more severe, just all over that bed. He was discharged just 4 days ago after experiencing pneumonia, so he was in the hospital, in that hospital, the hospital where you're working, 4 days prior with the diagnosis of pneumonia. He says he's been vomiting off and on since he was discharged, and he's somewhat unhappy about that because he feels that they discharged him too soon. So that's what he's unhappy about. But he's very, very dramatic. So what history assessment are the priorities at this moment? Given this is all you know. I'm sorry? Respirations? Why do you care about that? He's short of breath. So you have a symptom to link that to. That's always good. What else? You're gonna do respiratory and GI assessment. Okay. Anything else? Is there any history? Let's start with history. Anything history-wise you want to ask him? I'm sorry? What his medical history is, right, other than the pneumonia, we know about that one. What else, other conditions he's had? And frankly, I'll tell you, sometimes if you'll just ask for their medicine list, you can then figure out what the medical history is and clarify. I always like to do that in the emergency department. Makes it sometimes a little more organized, but we're going to certainly do that. Anything else?
Was he born blind?
That's a very good question. Was he born blind? You know, or was this some sort of accident, or what caused him to be blind? Anything else that you're interested in? Yeah, maybe describe. He tells us if it's burning, really his pain, all of his pain, he talks about his throat, and it's sore, and it's burning, and it's about a level 5, but he's tossing all over that bed. Turning, tossing, flashing around. You know how sea patients do that before? You're going to ask anything about that? How long has what been going on?
How long have he felt the short of breath?
Okay, how long he's felt the short of breath, okay. Yes, is there anywhere else that hurts? That's a good question. About his what? Vomiting blood, okay, what does it look like? What's the emesis look like? That's a good one. Anything else that y'all can think of? And so assessment-wise, you're primarily focusing on respiratory and you're focusing on GI, but is there another area that you need to assess based on just what you have up here? Yeah, let's look at that inside of that mouth and throat. If he's complaining this much about that, because obviously something else is going on, but that's what's really focused on in there. You know, there is that perception where you can only feel one pain intensely. You know, you've heard that before, where you feel one pain intensely and the rest of them are kind of dull because of that. You have to suspect with this that that's what's happening, especially considering it just keeps going on about his sore throat. And but that wouldn't explain his thrashing about on that bed. I also asked him about that. I was the triage nurse that took care of him, and I asked him, said, you look like you're in a whole lot more pain than you're reporting. What's causing you to thrash around on that bed? Is something else hurting? That sort of thing, to try to get some more information out of him. He was not an easy patient to triage because he was so upset and thrashing about. He was loud, somewhat offensive in his comments, and those types of things. So y'all want to go between that. You do want to look and see, is this recurring pneumonia Or is there something new going on? So that'll be, when you do your respiratory assessment, you're gonna be trying to determine which one of these is happening. In the GI assessment, GERD often causes respiratory difficulty and burning in the back of the throat. So the GI assessment may lead you to understand what's going on with the respiratory problems. The number one cause of asthma in adults who didn't have asthma as children is GERD. New onset asthma in adults is most often occurs due to GERD. And it sounds like perhaps his vomiting or maybe some GERD is causing him a problem. You did want to know his past medical history, why he is blind. That's a really good question to ask him. And his current medication list. He's going to tell you when you ask him about his blindness that this is related to diabetes. So he became blind with his diabetes. So what we do know about him, he has chronic renal failure. He has hypertension, he has diabetes. He appeared to have difficulty breathing, he was agitated, he was thrashing around, and these are his vital signs. So what do you think about those vital signs? That heart rate and that respiratory rate are not good, are they? He had abdominal pain on palpation, although he wasn't really complaining about it. He wasn't, he did not just disclose that. They had to locate it. His bowel sounds are hyperactive in all four quadrants. His breath sounds are clear. He has an odd odor to his breath as if he's been drinking. He kind of looks like he's been drinking too. His skin is cool and clammy. His oral mucous membranes are pink but dry, but not inflamed. It didn't look like that this GERD or this vomiting had really caused much tissue damage. And he has a dry cough. He denies smoking or drinking alcohol, however. Has a burning sensation in the back of his throat, feels short of breath, nausea, states he's been vomiting for the last 4 days. So this is the information we obtained on him. He was unaware of his home medication. He told us he was on Caduet, Cosar, Clonidine, and furosemide. He did have his wife with him, but she was very anxious and unable to answer any questions. In fact, his wife is going to be absolutely useless in this entire process. She is a Looney Tune, let me tell you. And she does not enhance anything that goes on this entire night. It is Sunday evening when he presents, and his pharmacy is not open. So how will we get an accurate list of his medications? He was recently admitted. That was the best place we could get, is to go and get his medical record from his previous admission, which was just 4 days ago. And that's exactly what we do. Here are his home meds. So tell me what these tell us about him. What's Caduet? It's not just a statin, is it? And the reason I asked that is it says 10 milligrams / 20 milligrams, so that tells me there's 2 drugs there. A calcium channel blocker and a statin drug, is that what it is? The combination of a calcium channel blocker and a statin. How about Cosar, what is it? For diabetic neuropathy. Is that right? How about Clonidine? What is it? Yes, which type of antihypertensive is it? You told me this one's a calcium channel blocker. What's this one? That's what I thought too. I thought it was some sort of antihypertensive. Cosar is an ARB, is that right? So what is an ARB? Receptor blocker. It's an angiotensin receptor blocker. So it's the one he apparently couldn't take lisinopril. So they put him on an ARB. And how about Clonidine? What is it? It's an alpha adrenergic drugs. So all three of these have antihypertensives in them, don't they? So why is he having to take so much antihypertensive? He's what? Why does he have to take so much? He's not responding well to his antihypertensives. This is not surprising. He has two conditions that make it very difficult to treat hypertension. He has both diabetes and he has renal failure. So both of those make it very resistant. The blood pressure very resistant to antihypertensive. So he's on 3 different ones, plus he's on a statin drug for his coronary artery that's high cholesterol, which comes along with diabetes, doesn't it? I mean, that's just one of the things you have with diabetes is high cholesterol levels and you have hypertension. Furosemide, why is he getting furosemide? No, not his heart, he does not have heart failure. It's trying to push those kidneys to do something, right? It's trying to push those kidneys to do something. How about this Lantus? This is his diuretic, and this is his anti-diabetic medicine, and then this is as well, isn't it? And then what's this one? Yeah, I don't think it was for depression. I think it was for sleep. And what makes me think it's for sleep? Yeah, he's only taking it at bedtime. He's having trouble sleeping. That is not uncommon with people with these types of chronic disorders. Lots of things with renal failure and diabetes can cause sleep disorders. So those are his medications. Past medical history, this is from his chart. This is not from him, this is from his chart. In his record, because he's had more than one admission, there is some places that say he has type 1 and other places that say he has type 2 diabetes, with renal manifestations, hypertension, hyperlipidemia, osteoarthritis, and peripheral vascular disease. We're not surprised. The medicines kind of told us that, didn't it? So other than the osteoarthritis, the rest of them we knew. And I'm not too surprised that he has any kind of bone problems. He's got renal issues. He's not allergic to anything. Now, which assessment's priority for us to obtain? Given what we do know about him at this point, what do we need to do next? What assessment? Blood sugar, that's exactly right. We need a bedside blood glucose to find out what his glucose levels are. It was too high to determine. Have you ever seen that? So now what are you going to do? I'm sorry? You're going to get an IV side going and get a lab sample. We need to know what that glucose is, don't we? So what's likely causing these problems? DKA is what we're worried about. Exactly. So here is our little muse. Let's just chart him out. Heart rate is 102. Did you get a point for that? And his systolic's 132. He doesn't get anything for that, does he? How about his respiratory rate? Yeah, he gets 3 points for that, so now he has 4 points. His urine output, well, I really would not put that on this scale just because his normal is probably less than 80, but we really don't have how much. He is urinating some, but we don't know how much yet. Central nervous system, he's awake and responsive, so he doesn't get a point. His oxygen saturation is greater than 95%. So far we have how many points? 4. Yeah. So far we have 4 points. So he's at that point of being serious, but maybe not so serious that we need to notify a physician. So what are we going to do first? 2. And what interventions are you going to do before you get this physician involved in this guy's care? Think about it. You think he has DKA. You're not going to have medical orders yet. So what interventions are you going to do? You've already talked about a few of them. What are they? We're gonna get IV access. We're not gonna actually run any fluids yet, but we're at least gonna get IV access. We're gonna go ahead and order that glucose level, aren't we? There's a protocol for that. So we're gonna go ahead and run that glucose level. What else? We're probably gonna give him some oxygen. Very good, Gabe. That's a very good thing to do. Most likely we're going to, get him on a stretcher, get his head up, try to make him comfortable as possible. We don't want him to aspirate, so we need to give him some sort of bag to vomit into if he's going to vomit. And then we're gonna see what these lab values show and that sort of thing. When we get ready to talk to the doctor, the situation, what is our situation? I'm going to skip over this, and I want to go to assessment. Your assessment is what's your impression of what is occurring. Start there. What do you think is occurring here? DKA. Now then, think about that. Go back up and say what abnormalities you're going to put in that situation. We're going to talk about all the things that show us signs of DKA, right? Now then, we need to give background. What is not necessarily a sign of DKA, but could be information that's needed? His history of diabetes, and that the chart says type 1 and type 2, so we don't know which one he has. Perfect. The fact that he had pneumonia recently is a really good thing to tell him. Because what's the leading cause of DKA? An infection that brings that blood sugar up, and then what else happens? And if the infection brings the blood sugar up, and then what else happens that leads to DKA? Think about it. They have an infection like pneumonia, the blood sugar goes up. But what else happens that's going to let that blood sugar just keep going up to the point of DKA? He's not going to probably be using his insulin because he's vomiting, he's not feeling good, he's thinking, I'm sick. I'm not going to eat, so therefore I'm not going to take all my medication. That poor sick day care is one of the triggers, one of the main triggers of DKA. Because they don't quite understand, he's had diabetes for a long time, that when you're sick, if you have an infection, that's going to bring that blood sugar up all on its own. You still need your medications. And so most likely he's not been taking his insulin, and therefore he's in trouble. Now then, so sometimes it makes it easier to say what is going on. What do you think is occurring? Then go up and put your argument up in the S, and you're supporting, this is just stuff, and the background's just stuff that you need to, that relates to it, but not the problem itself. Is that what you want? Yeah, that's what we want. Okay, so this is what the doctor ordered when we notified them. And let's see what we've got. So WBC is 13.9. As soon as we see that WBC, what do? We go down to the differential and we find out what? He has a bacterial infection, doesn't he? So anything else? His hemoglobin's a little low. He's a little dry. The hemoglobin's 12, so 12 times 3 is 36. So his hematocrit's okay. His MCV is a little high. His MCH is a little high. His MCHC is okay. MCV and MCH being high tells us what? Talk to me. We've gone over this and over this. A macrocytic anemia, what are the two we have to be concerned with? Folic acid anemia and pernicious anemia. Which one do you think he has? Pernicious, because he has diabetes. And one of the effects of diabetes is gastroparesis. It's one of the peripheral neuropathies. And so they're more likely to have pernicious anemia. He's already told us he's not drinking, right? So most likely not folic acid. Platelet count's fine. So we know he has a bacterial infection. Probably has some vitamin B12 problems there. Okay, here's his glucose. Well, we know now what's wrong with him. But if we wanted to verify that, we could calculate his anion gap, and that is this calculation here. The lab where this was actually done just prints out an anion gap, and I always like to show you guys that this is how you do an anion gap. So you're going to take the sodium level, which is 123, and then you subtract from that, and you're going to put the chloride level plus the BUN. Is it the BUN? No, plus the, what is those? Carbon dioxide, that's right. Chloride and carbon dioxide, and then that equals this, and then you look at the reference range, which is this. If it's higher, then that tells you that it is an endogenous acidosis. That's all it does. So this tells us that there's an endogenous acidosis. You really didn't know that. You saw that. You do. This guy's got DKA, doesn't he? Also, this is the formula for serum osmolarity. It's a way of looking at dehydration. And this one, you take the sodium levels and you double them. So 2 times 123, which is the sodium level. You also add to that the BUN divided by the glucose, divided by the, what is it? That's right, it's just a constant. BUN divided by 2.8 plus the glucose divided by 18. And it tells us he's got 324 and high is anything over 295. So he's got some serum osmolarity, not because of the sodium, which is usually the problem with this, it's because of that glucose. And you know, with patients who have hyperglycemia, that they are dehydrated. They've got too much solutes in their blood. They are dehydrated, and that's the reason you've got to give them all that volume of fluid. They're losing a lot of it. It's osmotic diuresis. That's really what diabetes means. Diabetes doesn't have anything to do with sugar. It has to do with diuresis. So anyway, this patient's in a heap of hurt. Okay, so his total protein's low, so he's a little malnourished, isn't he? His albumin's low. Bilirubin looks okay. Anything else not looking so good? His AST is a little low, but not anything we would get too concerned about. His alkaline phosphatase is 220, but just about everything will alter an alkaline phosphatase, so I wouldn't be too concerned about it at this point. Here's his ABGs. So his pH is 7.244, so we call that what? Acidotic. And then we look at his PCO2 is low, isn't it? And then his HCO3 is low. So what is this? Metabolic acidosis. Could we tell that from this? Let's see, yes. Where does it tell us that? Which lab values here tell us metabolic acidosis? The chloride and the CO2, remember the CO2 is a measure of bicarbonate when it's serum. This is venous blood. Yeah, good. But we're not surprised. We know he has DKA. Here's his urine. Here's his urine. Glucose is high in that urine. So we were able to get a urine on him. He's got ketones. By the time we got all these labs, we were like, yeah, no big deal because we already knew, didn't we? We already knew it was DKA since we got that glucose. No surprise. So what do we think that they indicate? Well, we know that they indicate that bacterial infection. We know that they indicate that DKA. We know that they indicate a macrocytic anemia. What's this, some other ones in there? We already do renal insufficiency. Maybe gallbladder or pancreas inflammation. That, you know, remember the alkaline phosphatase? Not real high, but maybe there's some of that going on with those labs. So what the physician does is, in this case, he orders the critical care insulin infusion protocol. And that's this form that you have now. that actually came from this. Now, at United Regional in this day and time, you would use EndoTool, wouldn't you? EndoTool is a beautiful tool. But I always still like to use this one in class because it kind of shows you what's going on behind the scenes with EndoTool. This is what we used before we had EndoTool. So let's see, anything that has been, has an X in it was what the doctor wanted us to do. So the doctor wanted us to initiate an IV infusion flow sheet. Okay, fine, some sort of documentation system. The doctor wanted us to start an IV, and what fluid did he want us to run? Normal saline at 500 milliliters per hour. And then to mix an insulin drip with 100 units and 100 meals. Don't you love that? That just means we got 1 unit per meal, don't we? And that's going to make calculations a little easier. And we're going to piggyback that insulin drip into the IV using an infusion pump. And we're going to start an insulin drip. And this was the calculation. You were to take the finger stick blood glucose, or in this case, we only had a lab because the finger stick wouldn't read. You're going to take the finger stick blood glucose and subtract 60 from it, so everybody do that. It was 1,100, remember? 1,100 minus 60. And then you're to multiply that by 0.03, and that 0.03 is called a multiplier. And that tells you the number of units of insulin per hour. So what did it come up to? 31.2. So our rate on our machine would be 31.2. Don't you love that when it comes out? So we're going to have stuck this on a pump and run this IV fluids, the major IV fluids at 500 mils per hour, piggyback this insulin into it, and run it at 31.2 milliliters per hour. Now then it says specify both a low and target range, and this will be, and since he didn't write anything into it, the low is 110 and the high is 140. So we're trying to get this between 110 and 140. Why don't we get it to a normal rate? Why don't we get it in a normal range? Less than 110 is normal for blood glucose. Okay, because that insulin's going to continue to work. So if you were to get it to a normal range, then pretty soon your patient, even if you stop the insulin at that point, your patient would go hypoglycemic. We don't want to do that. We're going to check this blood glucose every hour. This do not use alternate sites. I don't know what that was all about, but anyway, that's what they have. Adjust the current multiplier drip formula according to the following directions. So whenever the finger stick blood glucose is greater than high, you're going to increase the multiplier by 0.01. And to increase by 0.01 every hour as needed. Whenever it's lower than the target, decrease it by, and whenever it's within target, don't change it. See that? That's the sliding scale they want us to do. And then if it gets less than 80, there's a little scale for what you're supposed to do about that. After 4 consecutive in target ranges, you can go to every 2 hours. And then it gives you a list of things to notify the attending physician if. It tells you to get a lab glucose if the finger stick blood glucose is less than 50 or greater than 375, and to consult the endocrinologist if it's not back in control within 24 hours. So this was just a protocol that we would follow with this patient. So if we started this, let's say we started it tonight at 5:30 in the evening, when would we reassess the client's glucose? 6:30, because it's every hour. And what is the target range? 110 to 140. And how often would you assess the vital signs? The protocol does not tell you that. Every hour when you do the blood glucose, okay, I like it. 3 hours after initiation of the insulin drip, the patient's blood glucose remains 625. The patient is now answering questions inappropriately, and his vital signs are 98 over 48, 66, 28. O2 sat 98% on 2 liters of oxygen. So what do you think about that? That blood pressure's decreased to the oh my God stage, hasn't it? You imagine this guy has had that low of blood pressure in years? No, remember he's resistant. He's got hypertension that is resistant to treatment. So what's going on? What could cause that blood pressure to drop like that? He's what? He's possibly losing volume. That's very good assessment. What could cause him to lose volume? Bleeding? He's bleeding? Is that the only thing?
Swelling.
Swelling? Mm-hmm.
Cerebral.
Could be fluid shifts, okay. All right. Now let's look at this. The heart rate is 68. Remember what it was before? Wasn't it 104? You don't see that blood pressure drop like that and that heart rate drop like that often, do you? Usually if that blood pressure drops like that, what's going on with that heart rate? That's right. So his heart rate is 68. He doesn't get any points for that. His systolic blood pressure is 98. Does he get something for that? 1. His respiratory rate is 28. 2. So now he has 3. Urinary output, do we have that? Is 170 for the last 4 hours. So he gets 1 point for that, right? So it makes him 4. He's now confused. That makes him 5. His O2 sat is 98%, which is good, but we are giving him oxygen therapy, so he gets 1 for that as well, right? So what is our decision? Notify the doctor, we have a problem. That's right, we have a problem. What problem do you think we have? What? He could be septic. Thank you, Christine, because that's what he is. He is septic. He is septic. I'm going to do a little lecture on sepsis because let me tell you, since the onset of rapid response teams, the incidence of cardiac arrest have gone way down. I mean, hospitals go months without ever having a cardiac arrest. They measure that. They give you a date how long it's been. That has gone way down. Unfortunately, when that emergency went way down, it opened us up to see what other emergencies we were looking at. And what we really started to realize is we're missing strokes and we're missing sepsis. And sepsis is when we really need early recognition and treatment, and so strokes. So those are 2 things that we need early recognition and treatment. And so I really need for y'all to understand what's going on with sepsis and how to recognize it. Because the earlier we do this, the more likely we are to save this patient. So we're going to do this a little breakout lecture here about sepsis. We're going to talk about septic shock. What is septic shock? Well, it starts with severe hypotension. Does this patient have severe hypotension? Yes. And the reason that it starts with that is when you become sepsis, the chemicals that are released will cause vasodilation. It'll cause vasodilation, and so you will have less pressure in those vessels. Now, you may also have an increase in fluid released from certain tissues, so that should stabilize that pressure somewhat. But those fluids can leak, and if you'll remember, his albumin level was very low. So he's going to be even at higher risk for having fluid shifts in the interstitial and intracellular levels because he doesn't have that oncotic pressure where he needs to have it to keep those fluids in. Remember, this guy is getting IV fluids at a very rapid rate, and his blood pressure was able to drop that low. That's scary, isn't it? That's very scary. But septic shock, severe hypotension, it's due to infection, which we know he had. What happens when you have this hypotension, this infection, the sepsis that goes on, it leads to an immune response. And if you'll think about the body, yes, inflammation is a wonderful thing, but it's a double-edged sword. It will protect the body from invading pathogens, but it will cause harm to normal tissues as well. And that immune response causes spread to the blood and tissues. The immune system becomes overwhelmed and chemicals are released into the bloodstream. Those chemicals are called endotoxins. Anything that ends in toxins is not a good thing. So endotoxins are released into the bloodstream. This causes systemic inflammatory response. Well, have you ever cut your finger on a piece of paper? I mean, does anything hurt worse? It gets so sore, doesn't it? It gets so sore. Well, look, and that's because of inflammation that occurs in that area. And I always like to remind y'all of the ORs, the 4 ORs of inflammatory response. Dolor is pain. That's right. Calor is heat. Rubor is redness. And tumor is swelling. So if you think about that happening from that little paper cut, imagine if that was going through all your body. How awful that will be. And that systemic inflammatory response leads to organ damage and organ failure. So this is what's going on in the body. That bacteria release endotoxins. This triggers that immune response in the bloodstream, and the arteries dilate. This damages the vessel walls, causing leakage. And we already had decreased albumin for this guy. Leads to lower pressure and could cause increased volume into the other tissues. You have lower fluid in circulation, that decreases perfusion. And if you decrease perfusion, then the brain, the heart, the kidneys, all of those very important organs do not work as they used to work. And the immune response can cause coagulation of the blood in the extremities, which decreases circulation. This is what's going on when sepsis occurs. And when this gets to the part where it is with this man, you've got septic shock. You've got septic shock occurring. The body is not compensating any longer. So what causes it? Infection causes it. But it can be caused by infections with bacteria, viruses, or fungi. It's not just bacterial related. We think his is bacterial related based on his differential dosing. The most common causes: pneumonia, bloodstream infections, kidney infections, urinary tract infections, and abdominal infections. We think his was caused by his pneumonia. The infection, when it spreads to the bloodstream, is called bacteremia. That's really the definition of sepsis. All this other is septic shock. Some things that cause people to be at risk for this: weaker immune systems. That was him. That was him. He had low protein. You've got to have adequate protein to have an adequate immune system, don't you? So inadequate protein, he was malnourished. That's going to make him have a weaker immune system. The elderly are going to have more problems with this. You know, always the old and the new are the ones that you have to be most concerned about. Pregnant women can have issues with this because pregnancy can decrease their immune response to protect that baby. Any long-term health issues? Well, he does, doesn't he? It's diabetes. Wounds or injuries such as burns, you can have that, or invasive foreign devices. These are things that can increase the risk of sepsis and septic shock. What does it look like? Refractory hypotension. Hypotension that is not responding to fluid replacement. Hypotension that's not responding to fluid replacement. Did I just describe him? Definitely. We're giving him 500 milliliters an hour, and he's got 98 over 60 something or whatever it was blood pressure. Lethargy or confusion, does he have that? Difficulty breathing, does he have that? Now he does not have a rapid heart rate. That is an ominous sign. It's a very ominous sign because he should. When you're in shock, your heart rate should go up, right? Cool, pale arms and legs, and that's because of that decreased circulation in those extremities. That coagulation that's occurring. Extreme weakness and lightheadedness, well, I don't think anybody got him up to find out if he had that, but I bet he did. Actually, he wasn't so strong when he got there. He was pretty weak when he got there. And nausea and vomiting, he's had that as well, hasn't he? So these are what sepsis looks like, especially septic shock. How do we diagnose it? We do blood cultures, that'll show us, but unfortunately it takes 24 to 36 hours to get blood cultures back, so we can't just wait for those. The CBC, especially the WBC differential and the platelet count. His WBC and differential told us that he had an infection, but it didn't, the platelet count didn't show that, it was normal. They'll also do lactic acid or procalcitonin levels. I think the evidence-based guidelines right now are promoting lactic acid, but I've seen both done. But they'll do one, there's no need to do both. PT, PTT, and INR, because of that coagulation that's going on, the AST and the ALT, BUN and creatinine, his are not going to be as informative because of his renal failure. Serum bilirubin and ABGs. So this is septic shock, these are the things that we're going to look at, sepsis or septic shock. They're going to do urine cultures, if there's any wounds, they're going to do wound cultures, any sputum, they're going to do respiratory cultures. Let's find out where the source of the infection is. These are the parameters that suggest organ failure. Temp greater than 100.4 or less than 96.8. So far, he has not had that. Heart rate greater than 90 at rest. It was when he got there, wasn't it? Respiratory rate greater than 20 at rest. Remember, heart rate and respiratory rates, when they're up at rest, that's a much more ominous sign than if it's with activity. WBC greater than 12,000 or less than 4,000. His at the time wasn't greater than 12, or was it right at 12? 12 point something? 13, so it was greater than 12. Those who sat 90% or less, who haven't taken him off of his oxygen to find that one out, to tell you the truth. Systolic blood pressure less than 90, or the mean arterial pressure less than 65, and his systolic is getting very close to that, isn't it? Urine less than 0.5 milliliters per kilogram per hour. However, in his case, this one is not going to be as diagnostic because he's got renal failure, or creatinine increase greater than 0.5 from baseline. Lactate level greater than or equal to 4. A platelet count less than 100,000. And an INR greater than 1.5, unless, of course, they're on warfarin, you expect that to be greater than 1.5. So these are the things that suggest that the sepsis is septic shock, and we're starting to see organ failure. Those are the parameters. So what are we going to do? Early recognition and treatment is essential because up to 50% of people die who experience septic shock. High mortality rate. We're going to give him IV antibiotics. We're going to give him inotropics, I should say inotropics, and vasopressors, corticosteroids, insulin, and fluid bolus as much as 30 milliliters per kilogram over 1 hour. We've been giving him a fluid bolus. If he only weighed 70 kilograms, how much fluid would that be? $70 kilograms, 150. About 150. So if he weighed 70 kilograms, and we're going to give 30 per kilogram, 2,100 in an hour. We're doing 500 in an hour now, but we've been doing it for a while. So it could be as much as that. They may also, over time, go in and do some surgery, not immediately, but they may do some surgery to get rid of any pus that might be accumulating if there is a place that, like a wound that has that, or also to remove any kind of dead tissues that are occurring, because that dead tissue is going to prompt even more immune response to it. The things that influence mortality, again, age, the old and the new. Overall health, his overall health was not good. He's a poorly compliant diabetic. We know that because he has renal failure and he has blindness with his diabetes. And he was how old? 57, 55, something like that. So he's managed to get in pretty bad shape in a fairly short amount of time. Whatever causes infection can have an influence on mortality. If it's something that's hard to treat, then that can make it even more likely that they'll die. How many organs have failed? He's already got kidney failure. So that is going to increase his risk factor. And how quickly and aggressively medical therapy is started. So we're going to do a blood culture. What are we going to do that? So talk to me. What are you going to do with this blood culture? Get it from 2 different sites. What else? So you go in the room and you're prepared. What's in your hand that you're taking to do this? Culture bottles. How many culture bottles do you need? 4. You need 4 culture bottles because you need 2 for each side. What else are you going to do? What else is in your hand to use to get this blood culture? Chlorhexidine. You've got some chlorhexidine to clean the site. Yeah, you've got chlorhexidine to clean the site. So what you're going to go in, you're going to find your site, you're going to clean it with chlorhexidine. Then what are you going to do? You're going to let it dry completely. Then what are you going to do? How much blood do you need? I'm sorry? 25 milliliters?
5 mils of blood.
5 mils of blood per bottle? 5 mils of blood per bottle? 10 per bottle? They're just kind of greedy, aren't they? Yeah. So you're going to put at least 5 milliliters in each one of those bottles. Then what are you going to do? Label it. Very important that you label it. What are you putting on that label? From what site you got it from. Of course, you're going to have your patient identifiers. You're going to have your name and ID or whatever it is, the time that it was gathered, those types of things. Exactly. And then you're going to do another site. And sometimes they'll ask that those be a few minutes apart, maybe 10, 15 minutes apart. Sometimes they'll just say 2 sites, that sort of thing. Good. The patient's prescribed dopamine, 3 micrograms per kilogram per minute, 6'2", and weighs 242 pounds. You obtain the following concentration of the dopamine from the Pyxis. So what rate will you infuse it? Do you have an answer? Let's hear it. 16? 16.5? 12.3? Must be 12.35 or 12.36 or something like that. 12.4 milliliters per hour. What's the volume to be infused? 250, that is right. Now then, let's keep in mind what we already have infusing on him. What do we have infusing on him? Normal saline, and piggybacked into that is an insulin drip. So where's this going? So we have to have what they call a dedicated line, right? We've got to go get another line for this dopamine. Good. I'm sorry? He needs a pick, yeah. Maybe, probably on this guy, they're going to put some sort of central line in. Yeah. What therapeutic response do you expect from this dopamine? His blood pressure will go up. This is one of the vasopressors, inotropic drugs. The blood pressure will go up. That's a good thing. What adverse effects most concern you? Can't monitor for therapeutic and adverse effects if you don't know what they are. Hypertension, what else? I'm sorry? Infiltration of the drug. Anything else? You'll have decreased peripheral perfusion. You ever heard the nurses, if you've been in ICU, you probably heard the nurses say, guys, be careful, their toes will turn blue if they don't get enough peripheral perfusion. You've got to look for that with these vasopressors. Certainly hypertension, that's not going to be our main concern. We're trying to get the blood pressure up. But if this drug does infiltrate into those tissues, it can cause ischemia and necrosis to that extremity. So we definitely got to look for infiltration. Okay. The client is prescribed amikacin, 5 milligrams per kilogram IV Q 12 hours. So what do we need to know before we administer this medication? How many of you brought the Gayheart I told you to bring? Oh, let's see here. Boys, did you not have a Gayheart book? You think I wouldn't notice you with your turquoise? Look at all these Gayheart books. Yeah, I'm impressed with that. Okay. I forgot to bring my index cards. I'm just using the back of this handout. Pass this around, put your name on it if you got a Gayheart book. Now then, let's look this drug up. We got all these Gayheart books. And monitor your neighbor. If Ricky didn't bring a Gayheart book, don't let him put his name on the sheet, okay? And some of you open them free. Hey, the pages aren't even separated. I've just look at the drug. I want you to look at, you're going to begin this thing, so figure out what you need to know to give it. I promise you, if you learn to use this drug in this book, you will love it. I loved it so much that I bought it and put it on my cell phone. Because when I was in the hospital, I wanted to have it at all times. It's a great book.
This is the worst book ever. Worst
Yes. So what do you need to know? It's nephrotoxic, so we're a little bit surprised that this is the drug they ordered, isn't it? Does it say anything in the book about what to do if it's ordered on a patient with poor renal function? No? Where would you find that? The daily dose, they tell you to reduce the daily dose, don't they? Or to spread it out so that you're giving it less often. So what is the standard dose for an adult? 15 milligrams per kilogram? Is that per day or is that per dose? It's per day divided by 2 to 3 doses. So if we divided that 15 by 3 doses, then we would have 5 milligrams per kilogram, right? But we divided it by 2 doses, then it would be 7.5. So they did reduce the dose a little bit, didn't they? But immediately, if I'm giving this drug, I got to worry about this person's renal function. He's already septic. He's already septic. What else do I need to know before I give this drug? I like that y'all looked up that it's nephrotoxic. What else do I need to know? I barely hear you talking, I don't know what you said.
So, that's also,
Allergies certainly, what else? Dilution, and how is it to be diluted?
100 to 200 milliliters.
So each 500 in either 100 to 200 milliliters? Okay, so we would, and this one is gonna be, what was he, 200 and, how much did he weigh? So he's 242, how many kilograms is that? 110. So 5 times 110 is 550. 550. So we need how much fluid? How much does it need to be diluted in? Every 500 in 100 to 200 milliliters. So if they put this in 100 milliliters, is that enough fluid? No, but he's got renal, well, but he needs volume, so we're going to give him some fluid. So we would probably put it in 200 milliliters, most likely like 250 or something, because that's what the bags come in, right? What else do I need to know before I give this? Rate of administration, and what is the rate of administration? At least 30 to 60 minutes. And if I was giving this 200 meals, I'd probably keep the 60 minutes. How about you guys? Yeah. And then there's one other thing we got to worry about. What is it? You've got dilution and rate of administration. What's the third thing with all IV drugs? Compatibility. Where are we going to infuse this one? Now we have an IV with normal saline piggybacked in as insulin. We got a dedicated line with dopamine. Where are we putting this one? It is PICC line that she got. Yeah, we're going to have another line, aren't we? We're going to have another line. Good. Very good. The patient's insulin rate of infusion is currently infusing with a multiplier of 0.05. You contact the physician and the physician tells you to increase the rate again. Remember, the blood glucose is now, what, 625, I think it was? So the blood glucose is 625 and you need to increase that based on this protocol. So tell me what rate you'll have it running now. So with the 625 glucose, the multiplier it's currently going at is 0.05. He wants it down below 625. Remember the blood glucose is 625? I'm sorry? 28? I got 33. Did you increase the multiplier by the 0.01? Yeah. You know, that's the multiplier it's currently going at. So he's wanting you to increase it. You got to go up on the protocol. It tells you to do the multiplier at 0.01 higher. So he's going to get 33.9 milliliters per hour. That's how this protocol works. This client spent a few days in ICU and then on to a progressive care unit, but he fully recovered from the sepsis and the DKA. In fact, he lived for at least another close to 10 years before he died. I'm sorry? 65. I'm sorry?
Just 10 years?
Well, he's 55, blind, and has renal failure. Like 80, and he had sepsis at one point. He fully recovered from sepsis. Almost nobody fully recovers from sepsis, but he did. He was a tough old thing. His crazy wife ended up leaving him. She was crazy. Okay, before we do dosage, I got a few little practice questions. Let's see how you do. The nurse receives the laboratory results of the kind emitted for sepsis. Which values need to be reported to the physician immediately?
Down B.
B, like in boy?
Yeah.
That's exactly right. Because that INR is up, that tells me that he's got that clotting, unless of course the patient's on morphine, we don't have that in the question. D-dimer indicates what? Clotting. Platelet count is less than 100,000, that's a sign of organ failure, remember? And the WBCs are elevated above 12,000, so that one is the correct answer. Okay, how about this one? Amen. How about this one? Which one? D as in dog? That's exactly right. Even if you didn't know the drug, most likely these could be reversed. This one's the only one that's likely to be, and it's because it is, not only is it nephrotoxic, it's autotoxic. So sometimes irreversible deaths can occur. Good job, guys. Y'all did good on this case. I'm pretty impressed with you. I'll go ahead and keep you around. Everybody keep passing my paper around with the gay heart, because I'll need that for my classroom activity. Where is it right now? Keep it going. Don't take the dosage quiz and forget to keep passing it, please. I got the dosage quiz.